let me thank Dr. Somani sir, whom I can call my brother, for the kind invitation and all the organizers. Now, in the next 15 minutes, I'll be just discussing probably for me the most important practice changing abstract, or probably the most important thing that we'll be seeing in the future, a single trial which has changed the destiny of around 45 to 50% of breast cancer patients. Some new controversy arising, but I think so this for me was probably the most important trial. I'm very brave enough to say in this year, if you consider all the trials taken together. Let me start with a trivia question. Who is this fair lady? Because the clue is she's the lead author of the main Destiny 4 study, and probably that is more important. The good thing was she was an Indian, and just the appreciation, she is a professor, breast oncology, MSK. Probably she was the main person who did additional HER2 new pie chart. Now, before this study, or till I can say till February, March, April, what we used to categorize was HER2 new amplified, which could be 20, 30%, but anyway less than 30%, and remaining 70 to 80% was HER2 new negative. We were least bothered about 1 positive, 2 positive. What was important is 3 positive or FISH amplified thing. But there came the new concept of HER2 new low. So how do we define HER2 new low? So 1 positive IHC or 2 positive with in situ hybridization negative. This constitutes around 45 to 50% of all our breast cancer patients, and that is important. Now, what we had was, currently there are no, still this drug came, there was no currently approved targeted therapy. Now, majority of this HER2 new are ER/PR positive. So 80 to 90% of this HER2 new subset in a general population will be associated with hormone receptor positivity. So the first take-home message is, if you are hormone receptor positive and your expression of ER/PR positive is high, so the chances of you having a HER2 new expression is very high, of the order of 60 to 70% against a ER/PR negative where this HER2 new expression is low. If you remember your CDK4/6 trials, first line PFS 14 months, and when you remember your second line PFS, basically if you remove your alpelisib study, which was 7 months, it is 4 to 5 months. So this drug really, and if you see the difference, talk about HER2 new low, no benefit of HER2 new blockade. The first thing to remember, the effect is what we call as through an antibody drug conjugate, and that is also a bystander effect. So the word bystander is more important. You don't need to block the oncologic signal. You need to deliver this drug in that cell. And let me start with the history. What is the medication used till now to treat this? So initially trastuzumab was tried, but only 1.5 months PFS and a response of only 2.5. It failed. And then TDM1. So all these drugs failed in this HER2 new low subset. And then the destiny changed. That is what I am trying to present. Now, trastuzumab deruxtecan, this slide has been discussed in various forums. The most important thing or a major difference with this drug is a higher drug to antibody payload, and more importantly, an effect of bystander anti-tumor effect. So this topoisomerase 1 inhibitor can penetrate your cell membrane and can go outside and kill the surrounding cell, which property has not been documented by your trastuzumab or a TDM1. So try to concentrate on 6 number. So a drug goes inside, dissociate, the topoisomerase comes, kill cell. But what was important was this drug or this topoisomerase 1 can permeate your membrane and go outside and kill the surrounding cell. And that is probably the most important effect of this HER2 new subset. It's all started. In fact, this was one of the very few phase 1 study which gained a lot of attention. And in fact, it was published in JCO. So 54 patients with HER2 new of 1 to 2 positive. 37% response in the 8th line. Please remember 7.9 line median and a PFS of 11 months. I have never remembered the data in the 8th line which give you a PFS of 11 months. And based on this unprecedented, there was never a phase 2 trial. From 1, it directly went to phase 3 trial And that was probably the topic of today's discussion. Destiny Breast 04 study. The population, again, the thing I told, HER2 new 1 positive or 2 positive with ISH negative. The dose was 5.4 milligram per kg every 3 weekly. Please remember, the primary endpoint was for hormone receptor positive patient. Now, I have attended a lot of debate that this is not the right. What about hormone negative patient? Please remember, when you talk about your HER2 no peptide, only 10 to 20% in the ERPR negative will have a HER2 neuro expression. So in the general population, only 90% will have some degree of hormone receptor expression. The second endpoint in overall population, I will like you to concentrate on the target population. 3 lines of treatment majority have taken. So it was the 4th line. Majority of them had taken, 61.13% had taken at least 1 line of chemo, and majority have taken at least 2 lines of hormonal. So these were hormonal refractory. More importantly, one thing I tried with CDK4/6, 70% had taken. So if you compare yourself with a BILEAV study, if you remember your alpelisib, that is what, so a heavily treated population. Now this was unprecedented. Remember your phase 1 data, 11 months. The progression-free survival in the primary subset was 10.1, an absolute gain of 4.7. Please remember 4th line with a 49% reduction in the risk of progression. But again, the same thing has been echoed by overall population. In fact, it was better in the overall population. So what we found out was the first phase 1 and phase 3 data was more or less equal, which is rarely seen in clinical practice. Now, this was the icing in the cake. A drug in a 4th line with a median overall survival of 2 years, 23.9 months, absolute gain of 6.4 months with a 36% reduction in the risk of death in hormone receptor positive, and the same quantum of benefit in all the patients. So here was one of the studies which in a 4th line gives you a 2-year overall survival with nearly 11 months of progression-free survival, which was never heard of in any of the studies. Hormone receptor negative. The quantum of benefit was better. Your hazard ratio is 0.46. So 54% reduction in the risk of progression. And more importantly, when you talk about overall survival also, this quantum of benefit remains the same. The absolute gain is 9.9 months. So if you remember your Sacituzumab data also, remember 12 months was your TROPIC study. It was 18 months. So a drug which works very well in a 4th line, giving you overall survival. Now affected or will impact your practice. This is the most important. So even if you have taken your CDK4/6 inhibitor, your PFS still is 10 months. Remember your 2nd line treatment in breast cancer in post CDK4/6. It was only 7 months, and this is the 4th line. If your IHC is 1+, still your PFS is 10.3 months. If it is 2+, it is 10.1 months. If you have taken 1 line of chemo, it is 10.9, and if you have taken 2 or 3 line, it is still 10 months. So see the quantum of benefit in a phase 3. Probably after 1st line, I think so in any of the subset, this may become the 2nd line, and in due course, because even in the 1st line, if you have any degree of your HER2 new positive. So this was unprecedented. 10 months PFS, 2nd line C, all your post CDK study, this was never heard of. Is the drug safe? So 3% grade 3 toxicity, but more importantly, how many discontinuations? 16%. So 1 in 6 or less than that, and only 4% death. The commonest cause of discontinuation was ILD, and the commonest cause of dose reduction was a hematological, probably due to that topohistological, followed by nausea, fatigue, followed by your diarrhea and constipation. Now, more important significant toxicity of interstitial lung disease, see your grade 4 and 5, 0.8%. Ejection fraction disease, grade 4, 5, 0. And cardiac failure, grade 4, 5, 0. So a safe drug probably, and we all know this. So what this study showed was first HER2 new targeted therapy to demonstrate improved efficacy in this. This was unprecedented, 50% potential improvement, your hazard. And probably there is no doubt, I think so, in this 50% of the patient, this is now the standard of care, or this drug will definitely be used. Second line, when I have shown you for both CDK4/6, but yes, drug once is critical issue. What this trial have changed? So this was the old concept. We never used to look whether 3 plus or fish amplified. But now the pathologist role will increase. You need to tell, pathologists need to tell, is it a 0 or 1 plus? As I'll be telling you, even in 0 now, they have to report whether it is ultra low or low. So any HER2 new positivity being a bearable, you need to be reported, because here the drug works very well, as I'll be telling in future. So the pie chart, if you see, HER2 new positive 15%, you already use this. In HER2 new low, which is 45 to 55% of the patient, you'll use this drug now, definitely. And in this 30 to 40 also, I'll be telling what is the future now for this subset of patients. The most two important challenges are important is HER2 new expression is unstable. See the left part of thing. In a primary, if the HER2 new is low and if the disease become metastatic, it may still come as 0 in metastatic. Similarly, if HER2 new is 0, even metastatic, it may become low. So that is more important now, that probably there are multiple factors contributing to it. But the most practical definition now that I have suggested is, if you had your HER2 new non-amplified, but any expression in any time, so even in primary, if you had your HER2 new, or even in metastasis, if there is any one positivity, please use this drug, because that expression is unstable and you will get the benefit of this drug. So this comes down to 81%. Please remember, this is more important. And the second challenge comes is 0 and 1 plus. If you look into pathologists, one pathologist may report 0, other may report 1 plus. Because if you say 0 is less than 10% cell, barely seen. And even in this subset, which is called as ultra low, I'll tell you the data that is very encouraging. So probably that is more important now. Reproducing what she told. This was a trial in HER2 new 0 subset, a DAISY study, which was presented. Now, if you leave, it was the duration of response, PFS was 4.2. Please remember, it was again a 7th line, and your duration of response was 6.81. Please remember, it was 0. The main premise is, even if you have 0 thing, it is less than 10% of the cells, if you say, that has some degree of expression. You consider it as 0. So here comes the study which might again change the practice. Destiny 6 study, where they are seeing in HER2 new ultra low. So even if it is 0, any sort of your HER2 new on IHC, if you have, you can give this drug against physician choice. So probably this is a subset we know in this setting. And a Destiny 8 study, where we are combining this TDXD, which is deruxtecan, with capecitabine, with the immunotherapy, with capivasertib, which is an AKT inhibitor, with a hormonal therapy, and with a fulvestrant. So in the future, you may see a combination of TDXD with all these drugs. You may use it in ultra low also, based, because phase this 0 also there was some response. Is it only the drug which has been used? So there are multiple antibody drug conjugate. More important being deocarbazine and disitamab vedotin. Actually, please remember this drug, I have presented a data in urinary bladder. The same HER2 low, there was a response of 40% with the PFS of 5.7 months, I beg your pardon. But again, will have multiple drugs in future, all based on antibody drug conjugate, which you may target this. You may probably sequence it also once you have this data available. Other drugs probably experimented who are being given in selective HER2 new population. Needless to discuss, but in future you will have 4 to 6 drugs which will be targeting the same subset of patients. And probably the future of this subset is also exciting and may get crowded in future. So this is what today with Destiny 4 you are covering another 45 to 50% of patients. Let us wait for Destiny 6 and this ultra low subset also. You may start targeting with trastuzumab deruxtecan. Here there will be probably, when you see what is being suggested, that in case of mass spectroscopy, that every breast cancer patient may have some degree of RNA expression of HER2. And so in future, probably irrespective of whether he is positive, negative, you might use this drug in all the subset. Maybe the quantum of benefit may be different. But as the future going, you have covered your 45, 50, another 15% with Destiny 6 probably will be covered, and the remaining probably in future with newer modality of detecting it, is mass spectroscopy, you will have this more. The last part, Does TDXD has a CNS activity? You discussed in 3 positive tucatinib. Please remember, this drug also has a very good activity in brain. If you see the 3 trials that were presented in this year, ESMO, in SABCS, 73% response, 44% response, and 73. Please remember, these were active brain metastasis. So based on this, I have not written it, but DEBRA trial, DEBRA-2 trial has been conducted now, which is including these brain mets in HER2 new low subset, and they are trying this TDXD. So probably added advantage in those with brain met with this drug, considering what we have gotten, 3 positive. So if I have to summarize, HER2 new low, I remember ultra low also I have told, and the data that has been presented. Please remember, I'm just presenting the data what Shanu Modi madam presented. Novel antibody drug conjugate delivers highly potent cytotoxin to HER2 new expressing thing, any amount of HER2 new, with clinically relevant activity observed in the metastatic setting. The diagnosis of HER2 new remains challenging, given that IC scoring was never developed to dissect these things. Please remember, it was for 3 positive. Now, the onus is on pathologists to report it. And in future, we'll have a lot of RNA-based technique, any amount of HER2 new in RNA, and you need to give this drug. Now, the most need of the hour is the novel HER2 new assays, and results from ongoing this Destiny Breast 06 may change our definition of HER2 new low. So it was more than 10% any, but now in less than 10 also, you might have to consider any HER2 new to be HER2 new low. And last but not the least is, we need extensive flexibility to adapt to future evolution of the definition of HER2 new. Probably more exciting data coming our way, lot of encouraging data which has been replicated, and for me this was the most practice changing or the most important subset that may change the destiny of our breast cancer patient. This was the last slide. That was, if you have time, go through ESCO 2002. What is our destiny? Should standard of care of patient with HER2 new breast cancer change as a result of Destiny 4? The answer is absolutely a big yes. But we need more sensitive tool to better define the most appropriate patient population. I thank Somani sir and the entire team for a kind invitation. Thank you all.
So there was a question in the chat box that being the dynamic marker, should we use the repeat biopsy to find out the low versus ultra low, something like 0 or 1, or if it is that coming 2, then do the FIS again. This was probably the question by Dr. Anuraj Purohit. Sir, would you like to answer this question?
Yes, sir. Absolutely. Sir, what I'll tell is it could be dynamic, but if it is positive at any point of time in the course of disease, you have to consider it and start treatment. So not present doesn't arise. The practical definition they suggested is, if there is presence in a primary or metastatic, please treat it with this drug. So should you do a biopsy? The answer is yes, you should do it, but probably the drug choice should not change. If you had positivity, what we now know is even in ultra low, it works. So why should you deny your patient the chance to give a good drug, which I feel might change all the paradigms in the future? If you say your 11 months PFS post CDK4/6, this has never been replicated. In fact, it was a 4th line and 2 hormonal, 3rd line hormonal. So for me, you should do your HER2 new, even if it is negative in metastatic, because being a dynamic expression, probably it could be several reasons that it could be negative. Your fixation problem, your probably the method that you have used. So I will not deny my patient, but I may do it because the quantitative benefit will be better. Higher the expression, more will be your PFS. That maybe that also in 3 positive, not in 1 or 2 positive, because in both these subsets, the PFS was more or less the same.
Thank you.